Good day, everyone. I would like to thank you for this opportunity of being invited to speak in this convention or post-grad for Philippine College of Lifestyle Medicine. And I would like to congratulate all the officers and members of this group. And today I would like to share with you the lecture that they requested of me, and it is entitled Exercise Prescription for Hypertensive and Post-Stroke Patients. My talk will be divided into three parts. So we will discuss first the definition, epidemiology of stroke, the risk factors, and of course, you will focus on the main issue here, which is stroke and the exercise program. And this is a very interesting topic because there are a lot of people suffering from this disease. And with the modern lifestyle that we have, there are a lot of things that we can do in order to prevent such things to afflict us or to happen to us. So let me go to the definition of stroke based on the American Heart Association definition. So it is defined as any condition that encompasses any acute neurological deficit originating from a vascular origin. And this is divided into two main parts. We have the ischemic, which is representing 85% of cases, and we have also hemorrhagic, in which case it represents 15% of cases. Of course, we have other types, which we will discuss later on as we go along with this lecture today. So stroke is the fifth leading cause of death and the leading cause of disability in the United States. And this was reported in 2020. This is a very recent study. And of course, it is also the second leading cause of death in China in 2021. So different areas, continents, may report different types of incidents of this particular disease. Now, if you look at the incidence of stroke by age, now this is a very interesting study by Vyas and colleagues. And if you will notice, I would like to highlight here the presence of ischemic and of course transient ischemic attack, intracerebral hemorrhage, and of course subarachnoid hemorrhage. These are different types of stroke, of course. And let me go over first the transient ischemic attack, which is the mildest form of attack. It may last for less than 24 hours. But interestingly, if you look at the age affected usually ranges from 18 to 30 years old. So these are very young patients. And you would say, why are there patients suffering from this? And you will notice later on that most of them is related to their lifestyle. And of course, a far second leading age is 30 to 39 years old. So as you can see here, it's very, very far from the second. Now it holds true with the ischemic stroke. Look at this. In ischemic stroke, the age is more predominant between 18 to 30 years old. Look at this. And of course, as you age, it becomes slower as well. And then the same holds true when you get a little older, actually at the age of 80. But if you shift towards the intracerebral hemorrhage, the age varies. So from the usual 18 to 30 years old, which is very common for transient ischemic attack and ischemic stroke, now it shifts to about 30 to 39 years old for intracerebral hemorrhage. These are the working group, very hardworking people, maybe career-oriented people, and maybe facing a lot of stress of lifestyle diseases because of the food that they have preferred to eat, and maybe because they have already money to buy those food. Now, as we shift from the intracerebral hemorrhage to your subarachnoid hemorrhage, again, the pattern is different. Here, you have 50 to 59 years old to be mostly affected. And of course, it may also secondarily affect 60 to 69 years old. So the age of patients differs. That's why it's very interesting to know this type of strokes and what age they occur, because you can actually predict what type of stroke you will eventually suffer just by analyzing the age group, and of course, without emphasizing too much the lifestyle that these people are doing. Now, this is a multi-center study of stroke from different countries, and as you can see, Philippines is one of them, one of the contributors of this study. Although the study was contributed to 2020, but the report was made 2013 for the Philippines. And look at the pattern. You can see here that the risk diseases where it is associated, risk factors. And then, as you can see, we have hypertension, diabetes, smoking, and dyslipidemia. And if you compare all of this, the most prevalent is dyslipidemia. So watch out for your cholesterol levels, 46.9%. Followed by, of course, hypertension at 28%, and smoking at 20.7%, and lastly, your diabetes at 5.8%. We used to always say, if you have diabetes, you have all these problems, which is also true. But if you look at this, you will be amazed that this is not only present in the Philippines, but if you look at other countries, the same pattern appears. Patients would have this disease and suffer from death, okay, due to the presence of dyslipidemia. So here it is very important that we emphasize this, because these are lifestyle factors that are easily controllable or modifiable. That is why it is very important to understand this, so we will appreciate this better as to what type of intervention we should do for these patients. Now, other facts that I have found out also here in this study is the atherosclerosis risk in communities found out in their study from 1987 to about 2011, although they reported recently, is that after age 65 years and older, there is a decline in stroke risk incidence. The same was reported by Cotton and colleagues. There was the same decline in stroke incidence, considering all those factors that may contribute in terms of lifestyle. And this was reported in 2020. And of course, recently, also, there was another study, a systematic review, that in high-income countries, we should consider Singapore, Hong Kong, US, Japan, there is a 42% decline between 1970s and early 2000s. So maybe because of the better intervention that they're doing for these patients. Now, also, sorry for that, there is what we call the stroke in the young, which we are seeing most recently for the last maybe 10 to 20 years. And the incidence is 30.2 per 100,000. It is higher in men than in women. And this is very interesting because they have a very peculiar pattern of this disease, as we will learn it later on. Then, of course, 10% of ischemic strokes occur in less than 50 years old. We already know that. And the recurrent rates of stroke is that, interestingly, 7.6% of those with recurrent stroke, we do not know the cause. Stroke of undetermined source. It's followed, well, of course, for those kind of unique, but this is also mainly caused by large artery atherosclerosis. So even if this is present, you can imagine how come there is this stroke of undetermined source. Okay, so what are the risk factors in stroke? Okay, so I divide this into three parts. what used to be just the risk factors are the non-modifiable and the modifiable, but I added one more thing, and I will show that to you later. So these are the non-modifiable risk factors. You cannot do anything about it: gender or sex, age, and then race, history of prior stroke, heredity, heart disease, low educational level. Of course, the age here could be whether what type of stroke would really happen to you. These are the hemorrhagic type, because as you can see, the ischemic stroke, the transient ischemic attack occurs for younger patients. So we would assume that these are the other types of stroke, the hemorrhagic type of stroke, although you can also find ischemic stroke in this age as well. So there is also what we call the medically modifiable risk factors for stroke. In other words, you can prevent this by pharmacologically providing patients with medication. So number one of this, which represents 91%, is of course hypertension. If you have a systolic blood pressure, persistent, consistent, 140 millimeters mercury, or a diastolic pressure about more than 90 millimeters mercury. So that represents most of these problems. And of course, dyslipidemia. As we can see from the previous chart, dyslipidemia is very, very high. So this one was studied by Hankey and Billinger, but of course, the other one was the more recent, which is saying that dyslipidemia really is the number one thing that could be causing the stroke. But in this case, in the sense that we are discussing the modifiable, dyslipidemia is also one of them, and hypertension. Hypercoagulability comes next. Elevated waist to hip ratio, the presence of diabetes mellitus more than 6.1 millimoles per liter, cardiac disease, high ApoB over high ApoA1 ratio. So that also contributes. And of course, stroke in the young, the deficiency of protein C. Those are the things that they found out to be contributing to these problems in stroke. Whereas there's also what we call the behaviorally modifiable risk factors. These are very important for our purpose because most of you here are lifestyle medicine practitioners. So what could you do? So if you can see here, there's a lot of things that you can do. Physical inactivity, obesity, alcohol abuse, drug abuse, oral contraceptives, diabetes, cigarette smoking, stress, lack of sleep, not considered to be independent risk factors for hypertension, lack of leafy vegetables in the meals, increased salt in the diet. And of course, in the lack of leafy vegetables, there's also that other thing of predomination of meat in the diet. So these are things that we need to consider when we advise patients as to what to do to prevent this stroke from occurring. Now, other thing here is that if you look at this chart, this is 2021, and Harsfield and colleagues made a study, and then they tried to see the relationship of lifestyle traits in stroke. And you can see that the more red it is, the higher the risk, or it is more significant. And so you can see here that the BMI, the waist-hip ratio, smoking are the ones that are very, very red. And of course, if you talk about the BMI and waist-hip ratio, we cannot just avoid looking at the physical activity. What brought about this? Of course, lack of exercise, right? So if you don't exercise, you will develop this disease in time. And so here, the stroke types and the risk factors, I tried to differentiate each of them. And so I identified 3: ischemic, cardioembolic, and hemorrhagic stroke. So since ischemic stroke represents about 80% of all stroke types, the risk factors here that is very peculiar is the level of cholesterol. So very, very interesting. And of course, cigarette smoking, and of course, diabetes. So these 3 are very important that contributes to ischemic stroke. And of course, an independent risk factor that is added here is the family history of stroke. If you have a family history of stroke, you have the tendency to develop all this stroke yourself. Now, if cardioembolic stroke is really interesting because it is expected. It represents 25% of ischemic stroke. So it's actually a subtype of ischemic stroke. So here, as you can see, if you have an atrial fibrillation, that of course is caused by irregular heart rate, regular pumping of your heart, and then it causes into atrial fibrillation. It throws out emboli into the brain, and so it's the one that causes stroke. So that's the risk. Now for hemorrhagic stroke, I was fascinated by this because in hemorrhagic stroke, most of the cases, 54.8% between 16 to 30 years old, are caused by structural vasculopathy. So there is a connective tissue problem in the blood vessel. And of course, for 31 to 45 years old, it's really caused by hypertensive intracerebral hemorrhage. And for both, it's 54.6%. Now, what is interesting here is that this is the one associated with hypertension and alcohol consumption. So patient who is drinking alcohol, we can always tell them, okay, if you continue doing what you're doing, you can have hemorrhagic stroke in the background of hypertension. And again, just like ischemic stroke, family history could be an independent risk factor. So if you know that you have that history, you have to be very careful that you don't drink alcohol and you control your hypertension. Now, stroke in the young, as I mentioned, is very interesting in the sense that there are a lot of patients who could be involved here. Then, of course, aside from the fact that there is a connective tissue issue here, and then, of course, there's an issue that patients may be having some protein C problem. On top of that, it could also be because there is an increase in blood pressure that could contribute to intracerebral hemorrhage, or eventually if there is a problem with cholesterol levels and triglyceride levels, then you can develop an ischemic stroke. So the same mechanism that you see in other patients. Now, so I would not be discussing the details of all the stroke because that's a very long topic. So I will now shift to the stroke and exercise. So what do you do? The objectives of exercise and stroke, as established by the American Heart and American Stroke Association, number one is to reverse the deficits caused by the stroke and minimize your impact. Can you actually reverse it with the modern technology? Yes. And prevent, recognize, manage secondary medical conditions, including recurrent stroke. Of course, a lot of times the patient would have a stroke, and they are also fearful about having another stroke. And of course, number three is maximize independence in the ability to perform ADLs. When we have a stroke patients, we would like them to be more independent as soon as possible, as much as possible, because we don't want them to always depend on people to do their activities of daily living. And number four, facilitate psychological and social adaptation and coping by the patient and family. And number six, we have optimized the resumption of prior life roles and reintegration into the community. Of course, there's a lot of stroke patients that you see around, and you will notice that even if they have some kind of a weak limb on one side, they kind of reintegrate into the community and they function very well. And lastly, enhance the quality of life by healthy and right choices. Now that they have a stroke, it's very easy to advise them, okay, you have to avoid this, do physical exercise, you have to arrange your activities in such a way that you will have more of the exercise, healthy food, and of course, fruits and vegetables would be very good as a choice for their diet. So there are different stroke recovery patterns. Now, what you see probably in the community is already a stroke that has recovered. But when you see an acute patient who suffered with stroke, now the extremities, one side of the extremity will usually have a very flaccid limb. In other words, you can hardly move it. Even if you move it, it's very flaccid. It falls off. You raise it up, it falls off again. So that is usually what you see in a patient with stroke. But when we talk about its recovery patterns, when do we expect? When I do some physical assessment for my patients with stroke, I always tell them it doesn't recover at the same time. So which recovers first and which recovers last? So usually the leg recovers first. That's the earliest. So the leg is very fast because, as you can see, this part of the limb is the one that is well perfused in the brain. And then when the penumbra, the area which is some sort of an ischemic area, plus there is collateral sprouting in that area, then that part in the lower extremities represent the brain is what recovers very early. So you can expect that. Now, in the upper extremity, what is the pattern? So it just like in the lower extremity, it recovers from the proximal to distal. So the patient would ask, Doc, I already was able to lift my leg. Oh, that's good. So that's proximal. And then, but you see the foot is still cannot actually dorsiflex. So in other words, can hardly move the foot. In the hands, he can hardly make a grip or even extend the wrist and hand. So that's okay. It will come. But just to emphasize that the proximal will recover first, the distal. In the hand function, it's first with the gross dexterity, gross movements. So you can actually handle larger objects. And as you go along, as you recover, then you can shift to the fine finger. That's why from physical therapy, for example, where they focus on the gross movements, then you shift the patient to do occupational therapy because they focus on the fine finger dexterity. So you didn't just refer it all to the physical therapist because the occupational therapist has also its own function. In fact, the speech therapist is also very important, the speech pathologist, as they call it. Because if we have any dysarthria, aphasia, then they are the ones responsible for restoring that function. How about muscle tone? The return to muscle tone is always from flaccid to spastic. So it doesn't happen that quick, okay? And he will explain that to you later on. And then, of course, you can see synergy patterns. When you see synergy patterns in the upper extremity, for example, we call it the flexor synergy. There is the shoulder is adducted and, of course, flexed, and, of course, the elbow is pronated, and then, of course, flexed as well. And then the wrist is also flexed. And then, of course, the fingers are flexed. So these are what you call the flexor synergy. And in the lower extremity, we call it the extensor synergy because it's an extended hip, extended knee, and of course, the foot is plantar flex. So that's the pattern of recovery in these patients. But of course, as I've said, it started as a flexidity and shift to spasticity. Now, let me just mention here quickly. If you have spasticity at the proximal portion, that is a bad sign of recovery. So there should be no spasticity at the proximal. So what is spasticity? It's a voluntary dependent resistance to passive movements. In other words, if you move it fast, there's more resistance. If you move it slow, then the limb usually follows. So that's what we call spasticity. And then, of course, early spontaneous recovery is expected within the first 3 to 6 months. We call that in our specialty as the golden period of recovery, because this is where the damaged ischemic brain regions will actually form collateral sprouting, and at the same time it unmasks previously latent functional pathways. Some people would say, actually, the brain is made up of a lot of neurons and you only use 10% of them. But if you have stroke, you kind of use other brain under neurons that are not working in order to compensate for the loss of that area which was affected by stroke. So this is what you expect in the stroke recovery. So why exercise after a stroke? Look at this data here. Now, when you have a stroke, the mean aerobic capacity of stroke patients decreases by 60%. That's a lot. Usually in the first month after stroke. The VO2 max decreased to 10 to 17 ml per kilogram per minute from 0 to 30 days. So in other words, if you don't do anything, that is exactly what's going to happen. When you exercise, the VO2 max increased to 12.6 ml per kilogram per minute while you're doing your rehabilitation. And your target, of course, is to be able to reach 60 to 80% of your target heart rate. You can either use it by using your 220 minus age formula, or the Carbonin's formula, or what they call the heart rate reserve formula, whatever you call it. And then, of course, this is not easily reached during among stroke patients. That's why there has to be an efficient use of muscles in order to reach this stage. Now, number two is impairment of cognition. Patient has a lot of problems with processing information, and of course, higher learning, things like that. And there is also a limb impairment on one side. And then this is noticeable during the first 3 to 12 months after stroke. Now, and guess what? When you do exercise, you actually improve cognition, and of course, you improve motor function. So we usually recommend that there should be a 30-minute duration, a moderate intensity type of exercise when we start an exercise for our patients. And of course, number three is there is a decline in cardiopulmonary function due to an impaired motor function. And of course, when we do exercise, those things improve. In fact, you actually decrease the risk of a second stroke by 80% simply by improving the cardiopulmonary function. Of course, we have poor locomotor and spatial memory. So early, moderate intensity exercise can also improve locomotor and spatial memory. And of course, last is post-stroke fatigue, which is present in 35% to 90%. Now, patient with stroke would always feel as if they're so tired. They hardly would like to cooperate with you when you do your exercise and your therapy. A lot of times you will see this when you encounter patients with stroke. They have to get a lot of motivation from you. Small changes that they experience, you should always highlight that, because that would be the motivation that you can encourage patients to do the exercise when you start doing it. Then, of course, what's the benefits of physical activity in stroke? Of course, it prevents secondary complications that are related to recurrent stroke and other cardiovascular diseases. And of course, it also affects the risk factors such as hypertension, arterial function, and insulin response. So in effect, when you actually start your exercise, you also modify the response of the body, and your hypertension, arterial function, and insulin response is changed. It is also a protective effect on coronary artery disease or first stroke in a dose-response relationship. The more exercise you do, the better the protective effect. And of course, exercise should be incorporated with other things like diet, use of cholesterol-lowering medications, antihypertensive medications, aspirin. It lowers the risk of a second stroke by 80%, and we mentioned that earlier. Aerobic exercise improves glucose tolerance in patients with stroke. And exercise and lifestyle modification improve your total cholesterol, body composition, blood pressure, and behavioral change. So what are the considerations when you do a stroke? The first question is always, or has always been, when is the best time to start an exercise, on a physical rehabilitation exercise? Usually, what we always tell everybody is once the patient vital signs are stable. Of course, the attending physician will always tell us, okay, it's safe to start. We always get clearances from the attending, and usually it happens if the attending is very aggressive. We can start right away within 24 to 72 hours, or within the first 1 to 7 days. The earlier we start the rehabilitation or the exercise, the better. But sometimes in our setup, the referrals usually happens when the patient is about to be discharged, and the and the nurse would tell you, okay, doc, he will be discharged tomorrow. Can you start the exercise today? Oh, so limited time. We cannot maximize the time of the rehabilitation or the exercise. So usually it is best to do it as early as possible, so that when the patient goes home, at least he can continue it, or if he wants to go back to the rehab which he would like to do, then there could be a continuation of exercise. Now, the other thing is, there are a lot of impairments in stroke, like motor control and strength. Once the body is weak, you have to grade it if it's ready to stand. If the patient has a grade of 3 or 3+, the patient would be able to stand actually. So motor control is very important. Sensory feedback. Sometimes the patient doesn't have any feedback. So you would like to know if the patient can really sense the leg stepping on the floor. Otherwise, even if you do exercise and you do not know that the patient's leg is touching the floor, there is no way you can treat. You can start an exercise right away. And sometimes there is what we call the neglect syndrome, especially for patients with right-sided involvement of the brain. One arm could not be identified. So if you do test, okay, we used to do test to be able to see whether there's a neglect syndrome on one side. Oh, the patient cannot identify. Doc, I don't know which area you touch, or this one or that one. So very hard. So if that is the case, that means we have a more challenging patient. We have to deal with him because he doesn't know that he has a left side or he has a right side. Okay, and then of course, you know also the neuroanatomical distribution of stroke syndromes. The other thing for elderlies, of course, is coordination balance. Patient will have difficulty balance. Now, it's very important to check the MRI or CT scan. Is there any cerebellar involvement? So at least you know whether you have to deal with balance problems. The level of spasticity is also very important because you can actually use spasticity to your advantage. In other words, if the patient has grade 3 spasticity, then you can use that for standing, for example. The level of language and communication deficits is important as well. So that when you talk, the patient can actually understand what you're talking about. So when you do your history taking, you can actually, you will actually be able to find out whether the patient gives you a feedback by him or her answering you back. You ask name, you ask where he came from, you ask his occupations, then he answered you back. So at least he can communicate with you, but sometimes shouldn't have that. And of course, there are other problems like bladder and bowel problems, which are very challenging as well. So we would like to follow the FIT model. For those of you, maybe you know this. FIT stands for frequency, intensity, time or duration, and the type of exercise. So the frequency could be from 3 times a week to a maximum of about 5 times a week. When you try to decide if his patient is inpatient, he would encourage every day, okay? But the moment he's discharged, we can probably do 4 times a week or 3 times a week. Intensity, low to medium intensity. So you can compute, okay? So usually maximum heart rate minus resting heart rate times how much intensity do you want to start? 60%, and then plus resting heart rate again. So when you do that computation, that is the Carvollin's formula, you get the target heart rate, and you'll be able to find out how to go about your exercise that it would not exceed your target heart rate. Now, higher intensity confers future cardiovascular events. Okay, so duration is 3 to 6 hours per week, or a duration of 26 to 40 minutes per time. 1 hour of exercise per week, okay, reduce stroke recurrence by 8.8%. 1 minute of exercise yielded a 1.3% reduction in stroke risk reduction. So you may start with 10 to 20 minutes and progress to 40 to 60 minutes. So, or what you can do is you stop every 10 minutes, short bouts of rest, and then resume again. And here, what is important is repetition. You have to keep repeating that. Sometimes patients would say, "Oh, I'm going to do it over again." So it's okay. You have to really do it because the repetition will register in your brain, and it becomes easy for you. It becomes your second nature. So types of exercise: you can do aerobic, you can do resistance, and you can do endurance exercise. You can start it within the 24-hour post-stroke period. The earlier it is referred, the better the performance. Okay. So the referral should be done within the first 3 to 6 months to the rehabilitation facility. And of course, when the patient is already integrated in the community, then they can do other exercises like walking in most cases, and the others would be running or dancing. If the patient is referred to the community, then you allow him to choose the kind of exercise that he loves to do. And then you can just modify that. If that is walking, then that's fine. If that is running, maybe you see how he compensates for the gait, so that he would be able to compensate for the deficit that he may be suffering when he starts running. So a combination of exercises is always better. You can do aerobic, at the same time strength training, at the same time you improve the flexibility. That's why you do a range of motion exercise, and neuromuscular exercises for balance, together with traditional Chinese exercise, which is also for balance and coordination. So in aerobic exercise, 40 to 50% of heart rate reserve could be progressed to about 60 to 80%. So you might want to start at 40, 50%. In my case, I would start 60, especially during the first week. And of course, 20 to 40 minutes and 3 to 5 days will enhance aerobic fitness. And then, of course, walking speed and walking endurance, especially in mild to moderate stroke. And this will also lower the cardiovascular risk. Now, the higher the motor strength, the more you should do the exercise, because usually you will not be able to notice, especially if the grade is only 2 or 1 or 2 over 5, then it's easy to recover the patient like that. Resistance training is very important. You know why? Because actually when you do resistance training, it attenuates or reduces heart rate and blood pressure response. That's why the question is, how do you do exercise for patients with hypertension, with increased heart rate? Choose a resistance training. So where do you do the resistance training? Usually you will have to do emphasize the lower extremity, okay? When you do your upper extremity, there's a tendency to increase the blood pressure, to increase the heart rate. But if you concentrate on the lower extremity, this will help a lot. And of course, it decreases also cardiac demands in doing activities of daily living. You can do 10 to 15 reps per set of 8 to 10 different exercises. Make it as fun as possible. The exercise for patients, you can make it as fun as possible for all those patients. And that is why in rehab or in the therapies should be a person who kind of play around with patients, and just to make it easy for the patients to adapt to those activities. And of course, flexibility in your muscular training, we mentioned this. It is intended to improve balance, quality of life, and mental health. Can you imagine if you ask the patient to do some work already, he would feel, wow, I'm going back to my normal activities. And of course, you guide him, because one thing that he's afraid is the fear of falling. Okay, so stratification of exercise and stroke. So we have phases of exercise. So prior to an exercise, what do? It is very important to do a graded exercise testing if it is available. But in the absence of a graded exercise testing, you can just use the Borg rate of perceived exertion and use the 6-20 scale, because there's a shorter one. And then 11 to 12 would be your target. So it's almost like hard to moderately hard, something like that. And it corresponds to 42% oxygen reserve. For those with hemiparetic limb, significant paralytic limb, instead of using that, you can use semi-recumbent bicycle ergometer. So, you know that bike, don't put any resistance, just let him pedal while on that bike. So there has to be somebody who should make an exercise prescription. Now, in our specialty, especially, we make a specific exercise prescription for patients. What one exercise doesn't fit all. So it is important that we assess the patients and decide which exercise would be appropriate for him or her. And if we do sinasabi ng dikahon thing, we would not be successful. So it has to be custom designed. And of course, you follow the fit model, and you can, since the intensity is lower, then you can compensate the intensity by increasing the what? The frequency and the time, or the duration. So increase the frequency, and then instead of 3 times a week, you can do 4 times a week or 5 times a week. And the duration should be longer, maybe about 40 minutes instead of the 20 minutes. So, and then of course, there should be rest in between. Customized activity goals and exercise prescription is assess the tolerance of the patient. During the first exercise, you have to see if the patient can tolerate it and don't push him too hard if he cannot. And of course, it also depends upon the stage of recovery. Is still at the flaccid stage that you need to do some orthotic device placed on the leg to be able to stand. Sometimes we do that. And of course, you check for the environment. Is it a flat area? Is it an uneven terrain? Presence of social support, of course, family, wife, of course, the presence of other people who's gonna support you, and physical activity preferences. Give him the opportunity to decide which one he likes to do. And then, of course, if there's a specific impairments, like, for example, cognitive impairment, like speech, and then, of course, there may be some bladder bowel problems. So you have to address that as well. Activity limitations, you have to also find out. And of course, participation restrictions. What restrict you from participating? So you have to identify that. So during the phase 1, the goal is to prevent complications of prolonged inactivity. Patient was lying down for such a long time. And part of that, of course, is to, when you do an exercise, is you have to ask what's the pre-morbid activity status. Because if a patient is sedentary and he's not doing that, and now that he has a stroke, you would like to do him let him do something that he's not doing previous to that. That's kind of a challenge for the patient. So you have to ask, do you do this? Do you exercise before you had a stroke? Do you go walk in the neighborhood, or do you do bike? Those are things that you need to find out, because that's where you have to benchmark your activity based on how his status prior to the stroke. And of course, you have to tell him about the regaining voluntary movement, and of course, recovering basic ADLs. At least you have to let him hold bigger objects instead of holding pens. Maybe you can let him hold bars and maybe glass for as long as you assist him. Not the glass, but the plastic maybe. And then of course, watch out for the conditioning syndrome, such as there is a loss of sodium and potassium, decreased blood plasma volume, depressed immune system, increased heart rate, loss of muscle strength. You see, 2 weeks of not doing anything, you already lose your muscle strength. Reduced peak oxygen, orthostatic intolerance. He has been lying down for such a long time. If you let him sit, the patient feels dizzy. That's why when we do therapy for patients, in the hospital, we let him sit first, because we would like to know if the patient can tolerate it. And then if he can tolerate that for at least 30 minutes, then we let him stand. Then when the patient can tolerate it, then that's where we let them walk. So you have to go through these stages, and you just don't say, okay, let's exercise. You have to go through the steps. Otherwise, it might cause a problem. And a warning here is that there is a possibility of developing deep vein thrombosis, especially if the patient was not referred to the rehab department very early. For example, a week of inability to move one leg, and then you notice that there is already swelling in the distal ankle, and if you check the pulse rate, it is faint. Think about something, why it happened. Because staying longer in bed could actually encourage the development of deep vein thrombosis. And if you move that leg with a deep vein thrombosis, you might just be throwing an emboli somewhere else. So be careful that we don't do that. Of course, early mobilization is always emphasized to prevent all those things that we have just mentioned. And of course, phase 2, regain pre-stroke levels, improve motor recovery, gait, upper extremity function, balance and muscle strength, motor skills, self-care training, occupational and leisure activities, progressive task difficulty, you do repetition and functional practice, cardiovascular and strengthening exercises. And of course, we can shift to a more active type of exercise like treadmill, cycle ergometer, and of course, recumbent stepper. Of course, treadmill may be not a good one, but you can use a partly recumbent type of bike that the patient can lean on. And then, of course, you can start with cardiorespiratory fitness training to improve tolerance and endurance and ability to execute your ADLs. Exercise program phase 3 is intended to prevent recurrence. And so you maintain an active lifestyle with physical activity limitation, personal preferences, use personalized tailored training sessions, week 9 to 52 weeks. And then of course, exercise lowers systolic blood pressure, lower BMI. So we mentioned that you use the legs, not the upper extremity. Yeah. So resistance training for those legs are very important to lower the hypertension. Exercise to maintain bone mineral density is also important. Exercise to improve coordination, balance, the neuromuscular training, as we mentioned, and of course, cardiorespiratory and aerobic exercise training to enhance glucose regulation, improve blood pressure, and improve arterial function. So what are the barriers? As much as you would like to do the exercise, there are still barriers. So patient-related barriers could be the patient is depressed. How do you know? The patient is not responding. He feels tired. You start an exercise, the patient will say, okay, can we stop now? Okay, you always expect that kind of feedback when you start your therapy. He doesn't want to go more than 30 minutes. Lack of perceived self-efficacy and negative belief systems. Oh, I'm gonna die now. I'm gonna die. I think I'm gonna die. I think I had stroke because I'm so sinful. I did this. And then of course, fear of falling. And of course, subsequent stroke. Those are patient-related factors, and these are barriers. And of course, the other thing is lack of social support. No family was around to help him. Lack of availability of maybe rehab or fitness resources. Lack of transportation. No one would want to bring him to the hospital to do the exercise. And sometimes lack of awareness. And they would say, oh, really? Do I really need to exercise? My doctor just said, oh, go home and do your exercise. Unfortunately, it's not like that anymore. In the past, it's like that. Nobody's interested to refer it for a rehabilitation. But this time, patients are well informed that they have to do it. Otherwise, there will be lots of problems in the process. And of course, sometimes cost. It's very expensive. Environmental factors could be access, no access, transport, and of course, cost. So that is why he doesn't want to go out, because there's no way he cannot access. And then, of course, the motivators of exercise activity. He is excited to go to an exercise activity because he will be able to meet like-minded persons. Same problems, they can exchange ideas. So this could motivate the patient. And then, of course, the desire to carry out normal, oh, I'm going to recover now because my son, my daughter promised me to bring me to somewhere, maybe abroad, maybe for a travel. So he's very excited. And then, of course, there are other self-reported functional benefits. He can drive. And of course, we have to assess the patient very well. Make sure there is no visual impairment. In other words, there is no visual neglect. Because if he has a visual neglect, he might not be able to see one side over the other. So those are very important things for stroke patients. Now, to end this talk, I would like to share to you a beautiful text. This is my favorite, actually, found in Isaiah 40, 30, and 31. It says here that even the youth shall faint and be weary, and the young men shall utterly fall. But they that wait upon the Lord shall renew their strength. They shall mount up with wings as eagle. They shall run and not be weary. They shall walk and not faint. What a beautiful promise the Lord has for us. If we wait upon the Lord, our strength will be renewed. God bless you today. Thank you again for listening and for your kind attention.